Can I call for Dr. Mazen Sinjab? Fantastic. So until Dr. Mazen Sinjab, Dr. Sabah Justaniya, can you tell us how do you approach a patient who is 6'6" and unhappy?
I think I don't want to ruin a presentation that is specifically tackling this subject. I don't remember when, but I read it in the meeting. But basically, the main thing is not to make him happy from the beginning by looking at factors that would make him unhappy, which is usually between the lines. And secondly, identify the reason why. It could be as simple as dry eyes and you just need medications, or it could be a low treatment, a small treatment zone, and so on. So I guess Dr. Mazen will start.
Fantastic. Dr. Mazen, back to you.
Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh. And thanks for the kind invitation. And I will try my best to run as a horse to squeeze the science into 9 minutes. So the first talk is about how laser profiles work and why we need to know the laser profiles, because if we know exactly how our laser is going to work, then we can avoid mistakes in input. For example, if you know that your laser is going to hit the 180 at the periphery, and then you find your laser is doing that on, for example, 80 instead of 180, then you know that the nurse has entered 80 instead of 180, for example. And of course, to avoid hitting the neck, which is the hinge. So we know the principles of the laser. If we ablate the center, then we are treating myopia. If we ablate the periphery, we are treating hypermetropia. And this is the myopic ablation profile. We know that centrally. And this is the hyperopic laser profile, where we see it is like a donut shape. And this is the astigmatic laser profile. Actually, all machines follow one of those paths that I'm going to talk about. And why I'm talking about the astigmatic in detail, because we usually hit the hinge while treating the astigmatism. So there are two types of profiles. The conventional one, they use the minus cylinder, and they optimized the modern technologies that are using the plus cylinder. So if we start with the, for example, minus two cylinder at 90, the minus cylinder profile will use it as it is, while the plus cylinder will convert into the plus cylinder at the perpendicular axis. Even the minus cylinder has two subcategories, either to go for pure minus or to go for cross cylinder. Now, for the pure minus, this is an example, simple myopic astigmatism, -2 at 180. And if it is hyperopic, it will convert it into minus. So as you see, +2 at 90 will be treated as +2 sphere and -2 cylinder at 180, the perpendicular one. And this is an example about the mixed astigmatism, -2 +2 at 90 will be converted into minus cylinder at the perpendicular. So simple myopic astigmatism will be treated as follows. First, the laser will treat the steep axis centrally in order to push it to be like the flat axis. And then, as you see, it is rectangular at the steep axis. And then it pushes both of them to be on the retina by ablating the center, as you see here. So the laser profile will be like this. It will be like this in this case. Now, simple hyperopic, +2 at 90, +2 -2 at 180. It will ablate the center of the steep axis and then the periphery for the +2. And this is the compound hyperopic astigmatism, and this is the mixed astigmatism. Okay, great. Now we come to the other one, which is the cross cylinder. It tries to split the cylinder into cross cylinder. So for example, -2 at 180 will be splitted into two perpendicular astigmatism. There is a way to understand this, but we don't have time. So this is another example. -1, -2 will be treated as like this. And the principle is just to make the following. The laser will ablate the steep axis centrally in order to push it halfway, and the periphery of the flat axis in order to steepen it halfway. So halfway, in order to save tissue as much as possible. So the rule here is to ablate the center of the steep halfway and the periphery of the flat halfway. Okay, great. So this is the profile of the simple myopic astigmatism. Although it is myopic -2, but there is some hyperopic treatment on the flat axis. And this is the simple hyperopic astigmatism. Although it is hyperopic, but there is some myopic treatment on the steep axis. And this is the mixed astigmatism. Now we come to the optimized, which is the plus cylinder. So it converts everything into plus cylinder. So -2 at 180 will be treated as -2 plus 2 at plus 2, 90. And of course, plus 2 at 90 means that we are going to ablate the periphery of the flat axis. Plus -2 sphere in order to give the shape of the final profile, as you see on the right. And so it will ablate the periphery of the flat axis. This is another example, -4, -2 at 180. So it will treat it as follows, -6 sphere, in addition to plus 2, 90, which means ablating the periphery of the flat axis. Sorry for these movements because of transferring it from Keynote to PowerPoint. Now, the compound hyperopic astigmatism, this is the compound hyperopic astigmatism, the periphery of the flat axis. This is mixed astigmatism, as you see. So now you can imagine what the laser is going to do. Okay, super. So why? To avoid mistakes in input and to avoid hitting the neck. Now, let's imagine the patient under the machine. Okay, this is the right eye, nose, and the ear. This is very simple myopic ablation. That's it, nothing special. This is -2 at 180. Remember, the laser will hit the periphery of the flat axis. The flat axis is the 180 because the minus cylinder is at the flat axis. Okay, so in this case, we can do the hinge superiorly, and by this, the laser will not hit the hinge. And if you do it nasally or temporally, then there will be hit of the neck. Now this is -4, -2. Because it converts it into plus, so there will be -6 plus 2 at 90. So the ablation will be somehow hyperopic at the 180, the flat axis. So at the same time, you can do it superiorly. This is the plus. Now let's assume this patient has +2 at 140. As you see, if we do the hinge superiorly, part of the ablation will come onto the hinge. So we have to avoid. Maybe we can adjust it 50 degrees away, for example. And this is, I think, the final example. +3 plus 2 at 90. So the flat axis, which is the 180, will be ablated. So we can avoid this axis. And this is for the mixed astigmatism. And this is mixed astigmatism at the same time, but the axis of the flat axis is 100, so it is against the rule astigmatism. Here, we cannot do the ablation, sorry, we cannot do the hinge superiorly. We have to avoid, otherwise the hinge will be touched. Now, you may ask, okay, why not to protect the hinge by the sponge or the wick cell? Actually, you are going to lose some of the laser profile. It will not fall in place on the bed. And by this, you are not protecting the hinge only, but you are making irregular profile laser treatment, because away from the hinge, the opposite side, the full laser will fall there, while here you are protecting the hinge, then you are losing the energy at that side. So you are creating irregular astigmatism post-operatively. So it is not like the heroic is not to protect the hinge by the sponge, but to protect it by making another place. For example, if you are using the microkeratome, or if you are planning by using the femtosecond laser. And these are such examples. So take-home message, in tissue-saving profiles, no worries about the neck if it works on the pure negative cylinder. In optimized profiles and cross-cylinder tissue-saving profiles, adjust the flap parameters, otherwise avoid the flat axis. And I am on time. Thank you. continue with
That's
that?
amazing. Yes, please, Dr. Mazen. Since we
Yes.
have 3 lectures back to back for Dr. Mazen, we'll take them all and then we'll continue our discussion
Thank
after.
you. Next, please. Start the next, please. Yeah, great. So, usually we don't start with a take-home message, but I want to give you this take-home message. Never squeeze science in 9 minutes, as I've been asked to do. Now, I'm going to, within the 18 minutes, coming 18 minutes, inshallah, I'm going to go through the 5 principles that we are using in laser-based or lens-based refractive surgery. Now, starting with the corneal tomography. Why do we need the tomography? Only for refractive surgery? No, in modern cataract refractive surgery as well, because it is refractive surgery. And of course, to see the ectatic corneal diseases, investigate, and differential diagnosis of irregular astigmatism. Now, what are the principles of measurements? When we talk about the power, just imagine the land. If it is steep, then it needs more power. And when we talk about the elevations, just remember the mountains and valleys. And if we talk about the slope of the cornea, just remember the general shape of the mountain, regardless of the tiny details on the surface of the mountain. Measuring corneal power, of course, there are 3 types of maps, and each type has its own benefits. The sagittal map to study the patterns, and the tangential map to study the contour, and the Gaussian map to study the shape and location of the cone. As you see, this is a comparison between the tangential map and the Gaussian map for the same eye, how the Gaussian map can give you the shape and location better than the tangential map. Of course, the patterns can be taken by the sagittal. Either it is symmetric with the rule astigmatism, against the rule astigmatism, oblique astigmatism, or asymmetric. Just remember, symmetric or asymmetric. We come to the elevations. Of course, we need sea level. We don't have a sea level on the cornea, so the computer will create a sea level, according to which anything above is plus and hot, anything below is minus and cold. So in the hourglass pattern, as you see here, it is just opposite colors to what you see on the curvature map. So for example, the one on the left, although they are in minus and it is in cold, it means that it is below the reference surface, which means it is steeper. So this is with the rule astigmatism on the left, and in the middle it is against the rule astigmatism, and on the right it is oblique astigmatism. And remember the asymmetric patterns on the elevation maps. Measuring corneal thickness, of course, corneal thickness is a thickness, but we study the patterns. Asymmetric maps, either dome shape, which can be with eye rubbers, too much rubbers, or contact lens users, or maybe it is an early stage of keratoconus, and the droplet, which we usually see in keratoconus, especially it is converting into pellucid marginal degeneration, so early PMD. Bell shape, which is characteristic to PMD, and globus, characteristic to keratoglobus. Now, there is as well thickness to the epithelium, and the epithelium has properties of filling the effects, as you see here. The epithelium thickens over the valleys and thins over the mountains. As you see, this is over the intracorneal rings, and we can see as well the same patient over the corneal rings because it's very thick here. Now, this is after myopic treatment because the cornea is flat in the center and the epithelium thickens, and this may explain why we have some regression after treatment, especially if we are using small optical zone to save tissue, which is wrong, of course. And the epithelium shows different patterns in the ectatic corneal diseases, like the focal thinning, like the inferior-superior asymmetry, and another type of inferior-superior asymmetry, and sometimes the radial thinning. It shows like radial thinning. Okay, now we come to the simple interpretation of the tomography. Of course, we have to check both eyes for maps. This is the least, the minimum, all right? And just remember these cutoff values. I will go through the evidence based of that. So the KM, the thinnest location, the shape, and some numbers on the sagittal curvature map, in addition to if there is a skewed radial axis, in addition to checking that the elevation maps are in 8 millimeter diameter, not in other diameters, otherwise we cannot interpret. And then if it is best fit sphere, then we look at the value corresponding to the thinnest location. And we can use this table taken from Bell and Ambrosio studies, and then we look at the pattern of the thickness map. Okay, super. So regarding the KM, this is the evidence-based, no time to go through. And for the thinnest location, it has been shown that according to those population, the normal should be more than 470. But some populations may have thin corneas by default. So you have to check your population as well. Then we come to the inferior-superior asymmetry. You can take it from the topometric, and it should be the cutoff value here, 1.4 and less, let's say. And there must be no skewed radial axis more than 21 degrees, but we can forgive it, let's say, when the amount of topographical astigmatism is less than 1.5. If it is more, then we consider it as significant. Then we go to the thinnest location. For the thinnest location, if we are using the best fit sphere 8 millimeter, then we follow the table. This is the table. I made some approximation of it. So if the patient is myopic or emmetropic, the cutoff values are +8, +18, anterior and posterior. And if the patient is hyperopic or mixed astigmatism, then +7, +27. And if we are using the best fit toric ellipsoid, 8 millimeter, as recommended by Jack Holliday, then we look at all numbers within the central 5 millimeter, so not corresponding to the thinnest location, and it should be less than +12 on the anterior and +15 for the posterior. If you are using the Galilei, there is an index called the AAI within 6 millimeter, and it should be, let's say, less than 22, otherwise it will be suspect or abnormal. When we look at the corneal thickness map, no numbers, just we look at the pattern, as I mentioned before. And in addition, there is a very important spatial profile, which gives you how the progression of thickness starting from the thinnest location towards the periphery. Because usually, there is a quick slope, a quick progression when there is an ectatic corneal disease. In addition, you can check the average, which must be less than 1.2. The relative pachymetry map, recommended by Jack Holliday as well, which is like a comparison between the thickness map of the patient with the average population, normative data of the average population, and these are the cutoff values. Don't forget to compare both eyes. You cannot make a decision based on only one eye. And this is a study making some cutoff values and parameters when you compare both eyes. Now we go through these golden rules. When we say steep or flat cornea, when we say symmetric or asymmetric cornea, is it just based on colors? No. Actually, the average population, the KM of the average population is 43 diopters for the anterior surface. So above which it is steep, below which it is flat. And symmetric or asymmetric, it is based on the inferior-superior asymmetry, as we mentioned. Now, thin and thick, this depends on your population. If the average thickness of the population is 520, then if it is more, then it is thick. If it is less, then it is thin. I'm asking you now some questions, but no need to answer because no time. Just think about the answer. The least important tomographic feature of keratoconus is thinning. This is the least important. Do not be distracted by a thin cornea and do not be deceived by a thick cornea, because this is a case of keratoconus with a very thick cornea, and this is a case of normal cornea but thin. So thickness does not say it is keratoconus or not. Which one of the following would indicate a possible keratoconus? Increased posterior corneal elevation. Evaluate the posterior surface because ectasia starts there. This is a case of keratoconus. Now, high symmetric astigmatism is an indicator of nothing. So don't depend on amount of astigmatism. in screening for refractive surgery, the most suspicious sign is asymmetric cornea, not thin cornea or steep cornea. Look for any clue of real asymmetry. Always study both eyes and do not make a decision based on only one cornea. Now, yeah, thank you. Now, we move to the other one, which is corneal wavefront. Of course, mashallah, Dr. Ahmed Saadi made it very, very easy now for me to interpret, how to interpret. Actually, we have to be sure that we are studying the 6 millimeter, all right? And we are studying the cornea in total, not only anterior surface or posterior surface. Then we usually click all off, and then we study the five main high-order aberrations, which are the N3, as mentioned by Dr. Ahmed Saadi, the vertical and horizontal comma and the trefoil, and the center of the N4, which is the spherical aberration. If you click them, then you can take the RMS of those things. And of course, below each one of them, you can see the Zernike coefficient in plus or minus, which indicates whether it is positive spherical aberration or negative spherical aberration, for example. If it is positive spherical aberration, we can imagine that the cornea is oblate, is flat. And if it is negative, then we can imagine that it is steep, like after hyperopic treatment or keratoconus. And then you can check the RMS if you are planning for IOL implantation, especially the trifocal. If you are using the Cyrus or MS39, you cannot choose. It will give you everything in total, so the cutoff values will differ, as we will see later. Now, the spherical aberration is responsible for the halos. The vertical comma is responsible, and horizontal comma, of course, for the shadows and the comet, as Dr. Ahmed said, and for the glare as well. And for the trefoil, it is the trifolium or the starbursts. Correlation with symptoms. Why we need to check the corneal wavefront? If the patient is symptomatic, coming for refractive surgery and symptomatic, which means that, okay, doctor, I feel halos, I feel glare, First of all, we need to correlate that. Is it related to the cornea, or maybe it is ocular, something inside the eye? If the cornea on tomography is absolutely normal, then it is from inside. If it is abnormal cornea, there might be something from inside and the cornea. For example, patient is suffering from glare, and this is his topography, and we can see that there is a comma. So the cornea is the source. And if we look here at the quality of vision related to the cornea, we can see the comet on the point spirit function, and we can see the very bad MTF curve for this patient. So the source is corneal. Now we come to example number 2. The patient is suffering from halos, but when we checked his topography, it seems very good, and the amount of spherical aberration is minus 0.19, which is nothing. And if we look at the quality, then we can see that there is very small trifolium, Mercedes sign, and the MTF is relatively good. So the cornea is not the source, but maybe something inside. Now we come to the anterior OCT. Of course, we need it in order to understand what's going on in the cornea when we have a complication. For example, the diffuse lamellar keratitis, to differentiate it from the central toxic keratopathy, and as well to check the pressure-induced stromal keratopathy, which deceives you by giving you false normal eye pressure, and you give more steroids, and it gets worse, and then you give more steroids. While if you just check the eye pressure with your fingers, you will find it very tough. So you just stop the steroids and you give glaucoma to anti-glaucoma drops, and it will be perfect. As well, for the epithelial ingrowth, you don't need OCT for epithelial ingrowth because it is very apparent on the slit lamp, but we need it in order to check the gap from where those feeding cells are coming. Because if you don't treat that tunnel, if you don't cut it, then it will recur again and again. Of course, it's important when you have any scar in order to check the depth. Specular microscopy, we have to study the cells in terms of count and shape. It's not only how many cells we have. And we know that the cells decrease by age, and they decrease by our hands when we do something inside the eye. So instead of having the decrease 0.6%, so it becomes 4 times more when we do any intraocular surgery with and without IOL. And remember to choose the best cell count when you choose any corneal graft, because 50% of the cells will be lost after 3 years. Of course, you have to compare as well between both eyes. Hexagonally, it is one of the terms for the shape of the cornea. It should be at least 60%, otherwise there is a problem. And polymygetism, it should be less than 40%, otherwise there will be an indicator of endothelial cells like the guttata or Fuchs. Finally, corneal biomechanics. There is a lot of measurement tools, but most of them are experimental and still not clinical. The only 2 clinical tools are the ORA, the Ocular Response Analyzer, and the Corvus. Now, of course, the idea of the Corvus came from the ORA, which applanates the cornea and measures the deviation of light with the inward and backward movement of the cornea. And then it gives you a waveform and it gives you some parameters. Great. Do we need to memorize the parameters? No need, but you have to check the flutter after the second wave. If there is a flutter, it means a weak cornea. So you have to be careful if you have this machine. And then it will show you whether it is compatible with keratoconus or not, and it gives you sometimes the probability. Then came the Corvus. Everyone knows Corvus. It gives like a display based on the CBI by Ambrosio, the TBI by Ambrosio and the CBI by Vinciguerra. And it shows these red, green, yellow bars down. But first, you have to be sure that you are choosing the correct option, because there are 2 options for the CBI, whether the cornea has been treated before or not. If you forget to do this and it measures the cornea and considers it as not treated before, it will show you abnormal cornea. For example, if you are looking for enhancement. So be sure that you have chosen the correct one. In addition, of course, the corneal biomechanics is good for monitoring, like the changes of stiffness after the cross-linking, or maybe it is becoming softer if the cross-linking has failed. So as a take-home message, never squeeze science in 9 minutes, and still I have 50 seconds more. Thank you.
Well, thank you, Dr. Mazen. I think you were the best man to deliver such concise information in a very short time. So we knew who to put in order to deliver the information required. So thank you very much.